2/3 women, 1/3 men, and this was the distribution of types of MS. So relapsing and remitting was a little over half, primary progressive about 18%, secondary progressive about 28%. So the MSIS 29 is a 29-instrument tool for evaluation of physical and cognitive status. It's been validated as an effective and valid tool for measuring MS symptoms. And for those of you who've seen this, and I'm sure some have, this is the so-called physical component, and these are the questions that are rated. And it's the ratings are done on a self-reported 2-week look-back period by the patient. This is the cognitive component of it, and the same sort of questions. This was, now if we start to look at our results, I've diced it a couple of different ways. So if we look at the outcomes of the patients on the physical portion of the MSIS 29 at these are the categories of response from markedly worse, worse, no change, improved, or markedly improved. What we found is that in 1 month, about 75% of patients had either improvement or marked improvement, falling off slightly at 6 months. Similarly, in the cognitive measures, something in the order of 67 or 2/3 better at 1 month, and 64% at 6 months. Just expressed another way, it's a little more visually understandable. This was the 1-month result for 158 patients on the physical scale, so improved and marked improvement, you can see on the right. Similarly, the mental health or cognitive scores at 1 month. Now this is the 6-month score for physical and cognitive. So we were seeing what seemed to be a significant effect. These were all significant at a p-value of 0.01. And for the patients, that means it's a statistically significant difference between what would have happened if there was no effect and an effect. And that was maintained in 1 month and at 6 months. Similarly, that was the physical scale, the same for the mental health scale, the same statistically significant outcome. So it seemed, at least in our clinical follow-up, our clinical trial, there seemed to be a statistically significant change happening. Now, as we go back and look at subsets, the idea was to see what factors may be affecting response. And so in this case, we looked at gender and found that the 2/3 women, 1/3 male, there really didn't seem to be a significant change in the outcome or predicted outcomes based on gender or based on age. The age range in our population was 14 years to 75 years with a mean of 50, did not seem to correlate with age. Interestingly, and this came up in the last talk, is based on the type of MS, was to see whether the responsiveness was different in relapsing and remitting versus primary or secondary progressive. And at least in our study so far, the answer is no. It's important to realize these are sort of midterm results. We don't have the final answer on this, but at least at this point, the response was not dependent on the type of MS. These are self-reported patients who are on disability. About 1/3 of the patients were, and probably as an expression of severity, no difference. Duration of symptoms was interesting. This kind of came up in the last talk, and there was a trend toward a change in response, nearly significant at a 0.06 level for a different duration of symptoms, which you'll see here, where patients with less than 15 years seem to have a steeper response and a higher rebound, if you will, compared to patients with a longer duration. But these are not statistically significant at this point. It's really more of a trend and this is an indicator for us to look at this as we continue to collect data. MS medications, this one to me was a very interesting one, and it kind of speaks to what we do when we ultimately do conduct a randomized controlled trial, is what do we do about patients who are on those disease-modifying or modulating medications, and that about a little over a third of our patients were, and that did not sort as a significant effect on the change in status on the MSIS-29. So it didn't seem to matter. We also kind of looked at total flow as a predictor of where people were. Again, this was not a significant thing, but there does seem to be a trend separating relatively high flow versus relatively low flow patients. Restenosis is, I don't know if it's the first question that's always asked, but it's in the top 5. And we don't know the answer to that. This restenosis data comes through patients who return for retreatment based on some other indicator. So we didn't include follow-up that included active evaluation after treatment to look for restenosis. And I'll talk about that a little bit. I think one of the problems is we don't really know what to use to do that. More patients were also potentially restenotic, although we don't have data on them. There was a trend towards shorter duration of MS symptoms, having restenosis, and a trend towards smaller balloon size for treatment, although those are just trends. We did not do follow-up MRs to look for new MR lesions, but there was one self-reported new lesion in the follow-up group. But it's another question about how we would follow patients in an RCT, or randomized controlled trial, to look for new lesions. We tried to look at where the angioplasties were done to see if that was predictive. Upper jugular veins versus lower jugular veins, there was no significant difference. You can see the distribution, kind of what people who are doing this would expect. The majority of lesions treated in the lower jugular and a lesser number in the upper jugular, probably a 1/3, 2/3 kind of split. Balloon size also not significant, and this maybe is a little bit of a difficult thing to describe, because balloon size is really not as probably important as the philosophy of how you treat the lesions and how you select balloon size, because everyone's jugular vein is going to be a little different. And we use a sort of standard interventional radiology approach and slight oversizing of balloons. But that, nonetheless, the size of the balloon and therefore vein was not significant. The treatments, given whether the lesions were in the azygos or jugular, didn't seem to matter. The majority of patients did have a jugular venoplasty, basically all but one, and about 70% had an azygos treatment, and no significant difference, and similarly with stents, no change in predicted outcomes. Adverse events we do track, had no major adverse events in the patients today. We had one, I don't know if it's exactly minor, but not major, is a delayed deep vein thrombosis in a patient who was wheelchair confined 3 weeks after the procedure. So that's a within 30-day problem. So as a summary of the predictors, none of the baseline clinical testing or treatment variables significantly predicted improvement at 1 or 6 months. Either MS subtype, degree of disability, degree of number of veins involved, balloon size. All of the patients, there was just no change based on those variables. The study does have limitations. The restenosis rate cannot be determined as they weren't systematically reevaluated. The operable method, though, for doing this, I don't think really is determined yet. And my personal take on this is that it may be venography, or it may be a physical measurement of integrated flow through an MR study. Not all MSIS-29 surveys were returned, and that possibly introduces a bias to the reporting of outcomes. So even though we had statistically significant improvement, if patients who got a lot better didn't return their surveys, that biases the data in one